So we have talked a lot about inclusion at this conference, and now we are going to talk about maybe the only thing that is more important than financial inclusion, and that is health inclusion. Because health is obviously a fundamental right, and the people on this panel, our keynote and also panelists, have spent their lives working on public health issues, and they have spent I was reading through their bios, and they're all like 25 years of, 40 years of, 30 years of working on these issues. And the idea is that this is the base layer, of course, for everything else that you're trying to do with underserved populations. And so we're going to really dig in to how blockchain, how digitization, and also how blockchain can help us achieve these health outcomes, totally focused on, or I'll say 80% focused on, those harder to reach communities, that more informal sector. So this is going to be an unbelievable panel. So you're all going to want to strap in to your chairs, and we will, hang on tight, as they say, and we're going to kick it off with Dr. Bhushan. So please, for some opening remarks from you, as you have led, as the first CEO, the largest government-sponsored public health effort, maybe in the world. So please, with no further ado.
Thank you very much, Stacy, and thank you very much, Algorand, for inviting me to this conference. When Algorand India Foundation invited me to be on their advisory board, I thought that probably I'm the least qualified person to be on the board. But as I've learned more about what you do and what the potential is, I have changed my views. You know, when I think about blockchain, the first thing which comes to my mind even now is Prime Minister Modi's remarks in Singapore in 2018. He was in a financial sector conference, and in his very inimitable way, he was very humorous. So let me just translate what he was saying into English. He said, you know, there is this rumor going around among the community of startups that if you want 10% more from your investors, then tell them that you are using a platform rather than any other business. If you want 20% more, then you say that I'm working in fintech space. And if you want to really empty out their pockets, then say that I'm using blockchain. And when I think about that, and I think that if Mr. Modi has to be here or in a health conference, probably he'll give the same advice. He'll give the same advice because health sector has same problems, or maybe even more severe problems as compared to the financial sector of trust, transparency, and accountability. And if you look at it, yesterday Nikhil Verma was talking about value exchange. And when we think of value exchange in health sector, we don't know what we are exchanging, because we don't know what is who is giving us that value, what is the qualification of that doctor, what is the services that is being provided, and if at all we need those services, right? And the same thing happens at various levels in the health sector. So health sector has been beset with serious market failures because of two reasons. One, that there is asymmetry of information and there is asymmetry of bargaining power. Some people have much more power as compared to the patient, and some people have much more information as compared to the patient, and vice versa. And if you look at it, this asymmetry of information plays out at several levels. It plays out between patient and doctors, or patients and providers, because patient many times doesn't know if the doctor is qualified. You go to the doctor, you see a lot of degrees, whether those degrees are genuine or he or she is a quack, we don't know. And when some prescription is given, we don't know whether that is the best approach or that is the best diagnosis. And when doctors prescribe any diagnostic test, we don't know whether that test is required or it's being done for some monetary or pecuniary purpose. Similarly, when the patient goes to a pharmacy, there is that lack of information whether the medicines that person has got are genuine, fake, or substandard, expired. That's also a problem. Same thing happens with insurance companies and patients. Insurance companies don't know much less about your history. Patients know much more. So in terms of past conditions, so there is that asymmetry of information. Same thing with insurance companies and hospitals. Hospitals can send bills to insurance companies for something which they have not provided. Again, there is that asymmetry of information. So this is all where probably blockchain can help. And if you look at the areas where blockchain can help, I can think of several areas, but for brevity, I'll just list out 4. First one is on data management and data privacy. As we've seen recently, in India, large amount of data has been leaked. It happened with AIIMS, which is the best hospitals in the country. It has happened recently with the COVID immunization records, or sorry, COVID testing records. And when data were there in a paper form, in registers, in some places, it was much more difficult to leak and share that data. But when the data becomes more and more digital, it will be much easier to share. And since given the sensitivity around health data, I think blockchain can play an important role in ensuring that we know where the data is, where it is stored. The second area is, of course, supply chain management. I refer to quality of drugs, where they were made, what batch number it is, and that it can play a big role in terms of ensuring quality of the entire supply chain management. Third area is the research and trials, where India is considered pharmacy of the world, and we also are in big way getting into generics. And in generics, you need to undertake trials and ensure that biosimilars have the same impact as the original data or original formulation. And again, blockchain can help in doing that. And finally, in terms of public health surveillance, there is a huge scope for ensuring that we have the right data, right information, and right response at the right time using blockchain. So obviously, there are large number of areas where we can use blockchain effectively, but of course, it will not happen automatically. There are major constraints. One major constraint, of course, is information, knowledge. For policymakers and others, technology, change management is a huge issue where the people who have the power right now or who are benefiting from current system, of course, will not be very happy in terms of making the system more transparent. And again, that has to be overcome. But again, I think this is a technology, if implemented well, can actually transform the health sector and can make it much more effective and can help India and the country, in terms of achieving our goal of universal health coverage that we are seeking to achieve by 2030. Thank you very much again.
So I was taking some notes on Dr. Bhushan's talks, and I appreciated, by the way, the very structured way in which you gave those talks, because it made for easy note-taking. But I was struck by, sometimes with anything, we can be a little bit of a hammer looking for a nail. And so what I appreciated was the way that you started out with some of the problems that blockchain actually purports to be able to solve. These issues of trust and transparency and accountability. So I'm going to want to kind of dig in a little bit more on that. And then you gave us 4 broad areas. And ladies, I'm going to ask you to comment or incorporate in some of these areas in your remarks as well, you are more than welcome to tell him that he's wrong and he doesn't understand anything, of course. But the 4 areas are in data management and privacy, supply chain management, research and trials, thinking about those, and then kind of public health surveillance more broadly. Now, it strikes me a little bit from your remarks, Dr. Bhushan, that these are areas that are at least most easily applicable to a kind of more formal health sector, a hospital-based sector, a doctor and maybe employee-type driven formal kind of health economy. That may not be completely true, and you can correct me, but it seems to me, and sadly for us on this panel, we have 3 women that are working almost exclusively in the informal and hard-to-reach sectors. And so we're going to want to do as a theme on this panel to kind of see if some of these broader lessons can also be applied more in the informal sector. So I want to give you guys just a chance to first, without talking about blockchain per se, introduce your organizations and your work. And maybe I'll just go straight down the line, starting with you, Mari.
Thanks a lot, Stacy, Matt, Anil, and Algorand team. Delighted to be here. As you heard yesterday, the Self-Employed Women's Association is one of the largest organizations of its kind anywhere. It's an organization of 2.5 million informal women workers, but it's not just a national union, it's also a movement. There are many different collectives and cooperatives within the Seva family, including our health cooperative and insurance cooperative, which I'll be referring to in my remarks.
And which you run for Seva.
Yes, yeah. I do. But just quickly, more broadly, we organize women for their economic empowerment through 4 pillars, very quickly. Work and livelihood, employment, which we know is the lifeline to survival and out of poverty. Social protection, which is my area of work. Then capacity building, and what we've been hearing from yesterday, voice and representation. Nothing for us without us, a place at the policy table. So these are the 4 pillars we find for women's economic empowerment and self-reliance. And I'll stop there for now.
Okay, thank you. Julie Hudman, do you want to talk about your varied and storied career in health?
Sure. Hi, I am super excited to be back in India. I had the privilege of living in Mumbai for 3 years, and so it's been a while since I've been back, so I'm so happy to be here. I've spent most of my career in the US and most recently the last 9 years in Los Angeles. And I am working, I'm the managing partner of Vicasa Health, and I work with nonprofits, NGOs, government, health plans, helping them focus on our most vulnerable populations in America. And lately my work has been really around our unhoused and people living on the streets, and how can they access a system that we are, unlike India, we are in many ways over-resourced in our healthcare system. We have more money than we know what to do with. However, it doesn't always work very effectively, especially for the most vulnerable population. So that's what I'm talking about.
And also mentally challenged. Is that the right? Yes. You like the hard of the hard.
It's, you got to. I mean, I live in the richest country in the world, and we have 75,000 people in Los Angeles that literally live on our sidewalks and in the street, and it's just not right. And figuring out how we take our, I ran a Medicaid program. Medicaid is the health insurance program for the lowest income in America. It's a $730 billion program. It covers almost 25% of our population. And we can't get access to services of people on the street because they don't have identity. And so I'm learning how to use that language. So they're very simple things that are very similar to my friends and colleagues here on the panel of what, we do. We have the best pharmacy, all that, right. But we can't do the simple things.
Okay, so Urja, to you on what you are doing.
So, hi, I'm Urja Shah.
Setco, yeah.
Thank you. I'm with the Setco Foundation. I'm the managing trustee for the group, and I'm very pleased to be here. Thank you, Algorand, for this opportunity today. The SETCO Foundation works in what we say integrated community development, but largely health focused. So we work with the ICDS, for those of you who may know, it's the Integrated Child Development Scheme of India. We work with Anganwadis, which are early childhood centers. And the key focus is maternal infant health, early childhood, child nutrition, child malnutrition eradication, and so early childhood care. And we integrate that with sports for development and a few other supportive programs. I just want to share a little bit about sort of the scale of our program is small. We work with about 18 communities impacting 11,000 people annually. But I would say that the model that has developed, I think there's a lot of potential both in terms of the reach of the model as well as the use of technology now that could take it ahead. And why I want to talk about it is because when we started, Julie, when we first had the conversations, and Julie had been a thought partner in the early days when we started in terms of the rigor of how I'm looking at data and how I'm looking at health outcomes. And we had about 77% malnutrition rates in that region of Gujarat for children under the age of 6 and 88 for child. And today it's less than 12%. And the incidence of developmental delay and disability, which was at 40% in those days, is now at what is acceptable by global WHO census, less than 12%. And I think that is sort of what I want to maybe focus on, what sort of could be leading to some of that and how technology could help expand that.
Okay. So I, as the moderator, and as I consider myself the leader of this panel, I had an idea of how I thought we might do it, speaking in broad strokes, not making it so much about the blockchain per se. And I had a panel insurrection. They staged a coup, and they said, this is a conference about blockchain, and we want to get down and dirty into the gritty questions around what the problems can be and how blockchain can solve them. So, bowing before the masses on my panel, I want to focus this, not because it's worth saying, because you're doing so many other important things, and you have so many other problems, all of you trying to accomplish your mission. But let's focus this panel on the three sort of key issues that you talked about, Dr. Bhushan, which I want to make sure I don't misquote you. Trust, transparency, and accountability, which is already, big enough. And so, Marai, I want to start with you, but actually, before I start with you, I want to start with Ella Pratt. So she was the founder, of course, of Seva, and the founding, famous 50 years ago, one of the first organizations of its kind globally. And the founding story there is that there were self-employed women that carried textiles on their head between the different market stalls. And they were not being paid as much as men. Shocking, I know, to all of you 50 years ago. And so she made some noise about this. She noticed this, she made some noise about it, got some newspaper coverage, etc. And so these market stall owners took out a full-page ad in the paper and said, no, we pay women exactly the same as men. Here, okay. So the women went to kind of get paid as much as the men were paid, and they were like, what are you talking about? This is what you get, So Ella took photocopies of this ad, and she handed them out to the women and gave them to the women to say, look, didn't you take this ad out? Didn't you sign this ad to say that you pay the same? So are you going to pay us the same amount? And that, ladies and gentlemen, is the blockchain. She put in a public way that now couldn't be messed with, that they could use a very credible piece of information to fight for their rights in a way that was credible because it was not generated by themselves. Okay, so we are going to fast forward 50 years, though, and talk more about the kind of modern-day version of that. And I'll go down the line, and then I'll come back to you at the end to kind of respond to some of the things that you're hearing here. So can you kind of set up some of your problems in these areas, of traceability and accountability, and then we'll talk about solutions in the next round.
Absolutely. But I forgot to mention, I don't know how many people know here what is the size of the informal economy in India. Any guesses? It's more than 93% of upward of 500 million workers in the Indian workforce. And if I speak of the female workforce, it's almost everybody. 95% of the female workforce is informal. So you can imagine the scale of challenges that face us. I want to pick up on what you just said, Induji. One of the issues that we have been facing at the grassroots level, at the micro level, you spoke about the macro, is information asymmetry. And the way we've tried to address that issue, and it also is addressing the issue of trust and accountability, is setting up what we call Seva Shakti Kendra. Seva is a play on our name and it also means service in Indian languages. Shakti means energy, and also we use it in the sense of empowerment. So these are information and empowerment centers which are decentralized, which are embedded in the community, which are run by local frontline workers, whom we call in our Gujarati language Agevans, literally those who lead. And maybe we can have the first photograph so you can have the visuals that make it a bit more alive. These are not necessarily brick and mortar. As you can see, this is outside, and there are two nurses that the Agevan, who's in the orange salwar kameez over there, and she's in fact even taking blood pressure. At the back, there's health literacy going on, because part of information asymmetry is not just that knowledge of the services, entitlements, and schemes don't reach women, but also there's a huge health literacy gap. And that's where these frontline workers come in. Importantly, they help them also navigate the system. They help them, increasingly things are digital, which is wonderful, which is welcome. But there's a huge digital divide, particularly a gender digital divide. So it's these frontline workers like my sister over there who actually help them navigate these various portals. Fortunately for primary healthcare, you don't need to navigate portals, as you know, Induji. But for a lot of the other social welfare related products, for example, pension, you need to navigate, plus you need the documents. We heard yesterday about documents. Just a quick example, Stacey. A woman who I just met recently, in fact last week in a village, she spent a year getting her documents. She was widowed 40 years ago. She had no idea she was entitled to pension. She had an Aadhaar card, but the name on the card was different from the name on her public distribution ration card, we call it in India, for free food grains. So it was this woman who had to help her navigate the process, and it took a year. So these are the kinds of issues that we face. So it's important to digitize all of these, to come up with some kind of blockchain solutions for also keeping track of, how many times she went to which office to get which document. So I think here's something that blockchain can be helpful. And I'd like to also go to the next photograph. Here she is. Again, you see some are still using manual. Someone called it archaic. But in our condition where often connectivity and power is an issue, we have to do both for some time. But you can see very soon that many of the younger colleagues, particularly in our Seva Shakti Kendra, have adapted to digital. And we get the space from the local self-government, so free rental, and hopefully free electricity as well. Okay. So accessing the digital world has also been very important. And I have a few more things to say, but maybe I can come back.
Yeah, let me ask you a follow-up question, though.
Sure.
Why is it that you think you need some kind of a decentralized database? I mean, couldn't it be that the government could, in a kind of India-stat kind of way, control this information for your population?
Yes, and the government is doing that. But information and knowledge is power, as all of us know. And we would like this data to also be in the control of women. So that they know what's going on, they know, am I getting my pension, am I getting this entitlement, that service, and so on. So it's important for them to have access to the data, number one. Number two, our health cooperative, which is running these centers, it's also helpful for us to keep track and trace. So tracking and tracing, and then the issue of this documentation is really important. And
On that issue of data, decentralization of the data, the different kinds of data, Stacey. There's some data, for example, registries, those are centralized, and there is a central information and anyone can access those. But your own personal data, you don't want government to keep it, right? You want to keep it yourself, or it should be at the lowest level where it is used.
Absolutely.
So if government keeps it, that will be a big disaster, as we've seen it has happened in the testing of COVID data.
Yeah.
and urge-
Also, one more point,
let
there
me-
are
let me-
lots of pots of data.
yeah.
So the interoperability.
Yeah, the interoperability I think is
And
an important
portability.
point. But Urja, I want to turn to you, and if you could kind of put us in the body of your frontline workers and what they face, and how some of the challenges they face, and how maybe a better kind of data management system might work for them.
Okay, maybe I could share a short story around that.
Okay.
So I want to share a story of somebody who, she's one of the community workers who works with the mothers and children, and they take the data on child health in terms of the weight, the height, and how they're doing, to say just for one sort of data point, which is tracking the nutrition and malnutrition levels. And we noticed in a community that one particular community was showing really good results as opposed to the others. So we asked her what's going on. First, I thought there was data fudging. And after some time of sort of figuring out what, she was actually tracking her data to see that, before a child moves from what we call a moderate nutrition zone to a severe acute malnutrition zone, she was changing the protocols and interventions herself to ensure that there was a preventative process to prevent the child from sliding further. Now, most intervention protocols are very defined, like healthy child, green zone, moderate, yellow zone, red, severe zone. The fact that she could take the data and look at it and appropriately adapt the protocols, to me, talks about how empowering it is for frontline workers to have direct access, and also for the mother herself, because once she, and I'm just using a mother as an example of a community, that if I as a mom have access to sort of, this is my child's weight, this is my child's height, this is how it's tracking, I know when to call for support, I know when to call for help. And as a frontline worker, if I can map my protocols easily based on data coming to me quickly in real time, I don't have to wait for things to worsen. I don't have to wait for 1 month or a quarterly report to tell me where my community is. So I can take better steps. And as a worker, I can focus on trust building and relationship more than planning and data feeding and then taking those registers and putting them in an Excel spreadsheet, because I would waste a lot of time on that. Rather, I would use my time to, say, build a connection with you, Stacey, and have your family trust me when I come in and I'm supporting you, and have your entire family support that. So we can really change the focus when the data is accessible by the people who need to handle it.
And I'm guessing that the trust factor will go up when you show up informed and you know about the patient.
Yes.
Julie, I'm sure in the U.S. there's no problems like this.
We've got it all figured
You've got
out.
it all figured out. What I'm hearing, though, from these guys a little bit is some patient responsibility and ability to kind of have data and record it. But when you are working with the most difficult populations, how do you think about it from a garbage in, garbage out kind of point of view? Can you trust the data? Because the blockchain, again, as I always say, it is not about truth, it is about integrity. So how do you kind of prevent some of these issues with your?
And I think when I think about the challenges that we have, there really is the initial getting your proof of identity so you can go through the system and get healthcare and housing and other issues. I'm on a board of a nonprofit in Hollywood, and they are focused on the homeless services, getting the housing. But we also have a clinic based on our property and our organization. And really where I think about, besides the identity piece, because they lose it again. They get the birth certificate or whatever. They're living on the street, they get moved, encampments get moved. They move, they lose their information. So it's a constant cycle. So first the blockchain, hopefully to keep it where it's out there and they don't have to keep it on themselves and keep the piece of paper. But the second piece, which inherently is almost more important, is really on their medical records. So if we have this insurance system that is robust and has a lot of services, and there's a lot of providers. But it's difficult enough for any of us, we see different providers and we have our health records, and somehow we can remember where we go and pull this data or that data. But if you're living on the street, you might see a lot of different providers. mobile units, you might go into emergency room, you might do this, you do that. And they really, it just starts over and over again. And they have no access. Again, most of us don't in America anyway have access to our records the way we would like to. But for them, they are the most sick and they're constantly going into seeing different providers. So what it would give them, if, from my understanding of what I'm learning these last few days, if they could have something on the blockchain that was their own records and stayed with them, they wouldn't have to remember. Most of these folks are experiencing extreme trauma, mental illness, substance use, and when we go, we say, well, I had this and I tested for diabetes and I did this and I had that. They don't remember or know. Or if they do, they don't, it's hazy. So for someone like this who's very migrant, moving around a lot without any permanent home, having something that they actually own and everything is there, and that is somewhere that they don't have to keep it on them, would be an amazing way that I think about how my understanding of the blockchain could help.
Yeah, yeah, and I love how we heard in the last panel, start with use cases. So it's been good that we start with the micro, but now for our last minutes, I want to kind of telescope out and talk about some of the macro in terms of the things we talked about: surveillance, understanding the needs of populations, and whatnot. And let me start with you. And one of the issues that we have in thinking about the financial sector in transforming to the blockchain is that, like, nobody can kind of move first because the whole thing is so interconnected that you can't, unless everybody else is doing it, you can't. And do you have that kind of issue at all? And how do you break through?
Health sector is far more complex than finance sector because of the fact that it is very heterogeneous because there are large number of providers, different kind of providers, the people going to those providers with very different kind of ailments and which require different kind of support. And then there's the ecosystem of diagnostic centers and providers, the whole supply chain, which is again a different kind of a thing. So I see in terms of smart contracts, where in finance sector probably there are two players. In health sector, there are several players, and many of the players are very highly disadvantaged. And you have providers and patients. You have patients and insurance companies or payers, and then you have payers and hospitals. And all of them need to work together. And here, some of these players have more power over others. For example, doctors and hospitals, especially if you're already there and admitted, have much more power over you than others. So I think in that sense, I would stick my neck out and say that health sector has many more and much more important applications of blockchain than any other sector that I can think of.
Okay. Urja, let me play a little bit of devil's advocate for some of your earlier remarks. It seems to me that the power asymmetry and the information asymmetry are actually opposite asymmetries, that patients have so much information that doctors don't know about and can never get. And how do you think from a macro understanding at a population level what needs to be done when you can't 100% know what actually every patient is going through?
I think this is where if you have access to data in real time, at a sort of even a district level, or forget even a district, at a block or taluka level, you can sort of say, okay, this area seems to have more of this issue going on. Let's adapt what we are sending here, or let's send this much more over here. And even from a surveillance point of view, I mean, that really struck me because this was one of my earliest experiences. It need not even be at every health intervention, but something as simple, I learned this from what Whole Chain was talking about yesterday, that the government sends grains and nutrition support into every community for the population, irrespective of whether there is nutrition need or not. In the early stages, when there was a high rate of malnutrition, some of us used to intervene by sending food directly because we didn't know the government was supposed to send it. Somebody was saying that it's being sent to the communities and it's being sent to the people, but that pilferage was happening somewhere and there was no tracking. right? It's very easy to send in receipts saying that this one's got it, that one's got it. So a technology like this could really have that traceability and transparency to ensure whether it's medication, whether it's food, whether it's vaccines, all these things are going down to the last mile, which from a public health planning standpoint, even at just the physical part, is really, really important.
Yeah, that's a very interesting point. And Julie, let me go to you, and Mariah, we're going to give you extra time because anybody that signs an agreement with the Algorand Foundation gets more time on their panel than they're originally allocated. But Julie, let me we heard that nothing is kind of more use for the blockchain, but again there is this then health. But again there is this coordination problem, and if you think about all of the different kind of agencies and players and stakeholders that you had to work through, do you have advice on how to kind of break through that nobody can move first without everybody else moving kind of issue in terms of the execution of this?
In the American setting, I can only just think about that from an individual. So the public health and the data out there, I think we do a good job. And we have that data and we can access it for policymaking and other things. But from an individual and caring for that person, I don't know how you break through it because, again, even if you're not the most vulnerable, even if you're just us, coming in and trying to use different providers, you don't own your own data in America, and especially in healthcare. It's the biggest business in America. So you don't own it. A lot of other people own it, and then you have to try to get it. And so I think understanding how you can get it, how blockchain or other technology can allow you to keep it. But also we have a huge problem in America with, I would say, almost overdoing the privacy piece. And by doing the privacy piece, people keep their data, whether it be the pharmaceutical companies or whether it be the provider, they keep it because they say, well, we can't share it even with you without going through all these steps. So I do think that there's a potential for it to be better in the U.S., but I do think between amount of money and how much data is access to financial increasing for the providers, but I also think from an individual perspective, I think the privacy piece is hard. We're almost overdoing that where individuals need their own data a little bit better. So I'm hoping that blockchain technology can solve some of that.
Okay, Mariah, I wanted you to take us home on this, but it struck me that you are actually in charge of Social Security. So SEVA has very explicitly tied insurance and health and nutrition and other kind of in a holistic, whole health kind of approach. And how can you think about that? And how can blockchain help you think holistically as you've been mandated to do for your populations?
Sure. I think what Induji said is also true at the micro level. There's a real fragmentation of the health system and health services in India. So first of all, at the macro level, as we move steadily towards universal healthcare, there is a need to create that architecture, and both of us happen to be on a committee in working with the Indian Institute of Science in Bangalore, which is working towards this, and I think blockchain and more collaboration will be most useful. But I think at the grassroots level, it's taking care of the entire loop, right from primary healthcare, and I showed you the Seva Shakti Kendras, but also one of the biggest barriers to access to care is the high cost. We are largely a privatized system. Most Indians go to private care, whether they're poorer or richer, and that is what leads to catastrophic health expenditures, and that's where insurance comes in. And we've been able to, especially during the pandemic, hope we can go to, there it is, if you can see the slide, we've been able to develop an app which tracks and traces women, also enters all their information, and you can see she's using the app in the photograph and is explaining to women at the same time. It's very important also to have this sort of dialogue, interactive dialogue, so that technology and blockchain and digitalization is not mystified. So I think all along the chain, we're also another major cause of out-of-pocket. By the way, we have one of the highest out-of-pocket expenditures in the world, about 60%. So another point is running low-cost pharmacies, and I'm happy to say the government has taken up our model and calls it Jan Aushadhi. These are run by women 24/7. So here again, we need blockchain to help us with tracking and tracing and inventories, and all kinds of possibilities exist, I believe.
So, ladies and gentlemen, it all kicked off here today at this conference, and when we revisit this topic in this fine country of ours, I hope that we have at least tried to find a way to think about the importance of information and the idea that information is power, both for the policymakers and at the macro level, as well as for the individual patients, and as well as for the frontline workers. Absolutely. Having all of these perspectives, imagine everybody having the information that they needed to do their job that they need to do in the best way. And I think you all get badges of heroism for trying to work in an uncertain environment, and hopefully this technology more broadly can bring some of that information power to you as you try to do your life's work. Thank you very much, and please give a hand to my amazing panelists.